Thank you so much, sir. Respected chairpersons, my colleagues, and my dear students. I would like to thank Dr. Shamshad Begum, Srijit, Muralidharan, and the entire team for inviting me to present this topic on preoperative pulmonary risk stratification and optimization in non-lung resection surgeries. Well, you must be wondering, why should we do this risk stratification and optimization? Because we want to avoid post-operative pulmonary complications, and that can significantly contribute to overall perioperative morbidity mortality. There could be increased length of stay, and with it comes the cost. Now, why should we, what happens to the respiratory function under general anesthesia? Or first of all, let us understand the physiology. So what happens here is the nerve impulse from the brain causes a respiratory muscle contraction that causes an intrathoracic pressure change with an inspiratory flow followed by a gas exchange. Then again a respiratory muscle contraction, the lung recoils, and there is a expiratory flow from the lung back into the atmosphere. This is simple respiratory mechanics. Under general anesthesia, what happens is the pulmonary surfactant, what happens during wakefulness is, generally in a patient without general anesthesia, the pulmonary surfactant lining covering the alveoli reduces the surface tension and stops them from collapsing. So the oxygen from the air is absorbed across the alveolar wall into the capillary bloodstream, but the nitrogen, making up for about more than 80%, remains back and it stays behind. That's how we don't have collapse of the alveoli, right? But what happens under general anesthesia or in a patient of COPD? This is a normal lung, if you can see. So general anesthesia can affect the working of the diaphragm, reduces the deep breathing and coughing, and what actually happens is there could be less expansion because the surfactant levels are low. Higher oxygen will cause atelectasis, and all of them can lead to reduced lung function in the postoperative period. Under anesthesia, this is on wakefulness. Look at the diaphragmatic excursion on wakefulness and look at the diaphragmatic excursion under anesthesia. So what happens here? There is a decreased sympathetic reflex, vagal reflex, and splanchnic receptor reflex, and the diaphragm splinting occurs. There is more immobilization of the diaphragm. There is dysfunction, there is basal lung atelectasis, which I already told you, leading to VQ mismatch. So look at the, look at the fall in FRC with anesthesia. You can see that the FRC is progressively reduced as we start inducing anesthesia with paralysis and with surgical position. The FRC goes on reducing under anesthesia. And there is a 50 to 60% reduction in vital capacity and a 30% reduction in FRC for almost up to 1 week following anesthesia. So the changes in the pulmonary function, so in a crux is the lung volumes are reduced, tidal volume, there is loss of sigh during general anesthesia, functional residual capacity is reduced, there is diaphragmatic dysfunction, there is impaired gas exchange, the control of breathing is gone, there is depression of the respiratory system, and that is in fact manipulated more with opioids, and the defense mechanisms are completely gone. There is impaired cough reflex and mucociliary function. So basically through the postoperative period, the residual effects of the anesthetic agents can depress the respiratory drive and the ventilatory response to hypoxia as well as hypercarbia, and narcotics are adding to this insult and causing further hypoxia and hypercarbia in these patients, and also suppressing the sigh, which is much needed for all the patients. Even in sleep apnea, even sleep apnea is induced in many of the patients in the post-operative period. So this is in crux again, high FiO2 causing absorption atelectasis. Lower abdominal surgery can also contribute to this insult. So it's not just that only upper abdominal surgeries are giving rise to post-operative pulmonary dysfunction. So even lower abdominal surgeries can contribute, and the reduction in lung volumes are not seen with the surgery in the extremities. So what are the risk factors you have to look into? They can be broadly divided into patient-related factors and surgery-related factors. One of the most important is age, chronic lung disease, presence of asthma in the patient, general health status where ASA is more than 2, altered mental status, smoking, obesity, OSA, pulmonary hypertension due to any cause, heart failure, alcoholics, chronic steroid use, past history of stroke, preoperative blood transfusion, and a recent weight loss of more than 10% of total body weight, all of them have contributed to the risk factor of postoperative pulmonary complication. And the surgery-related factors are which site is the surgery being done, what is the duration of surgery, whether general anesthesia is given or a regional anesthesia is given, type of neuromuscular blockade, nasogastric intubation, and emergency surgery. So let us look into all of them one by one. So this has been reviewed by the Association of Chest Physicians, and they have concluded that age more than 50 years was an independent predictor of risk. And why? Because also by about the age of 50 years, you have cumulative comorbidities which comes with aging. Chronic lung disease, the odds ratio is about 2.36 times you can get postoperative pulmonary complication. In presence of chronic lung disease, the benefit of surgery should be weighed against the known risk. So if you look at this here, this is the airway. It is held open, whereas in a chronic lung disease like COPD, look at the disrupted alveolar attachment, mucosal inflammation, and mucus hypersecretion. So all of them will contribute to postoperative pulmonary dysfunction and complications in the postoperative period. Well, asthma. In a well-controlled patient with a peak flow of more than 80% of predicted or the personal best can proceed to surgery with average risk. Coming to smoking, it increases the risk even among those with those without chronic lung disease. The risk declines only after 8 weeks of pre-operative cessation. However, paradoxically, those who had stopped smoking less than 8 weeks earlier had a higher risk than the current smokers. You might have to ask why. It's funny, isn't it? So those who have just stopped smoking against those who stopped less than 8 weeks have higher risk. So the thing is, as soon as you have stopped smoking, there is a short phase of hypersecretion. So if surgery is done during that phase of hypersecretion, the incidence of postoperative pulmonary complication is that much higher. Obesity, again, there is stiffening of the total respiratory system. There is reduced lung volumes and chest compliance, reduced tidal volume, short rapid breathing pattern are there. There is reduced vital capacity. There is increased risk of airway closure and ventilation distribution abnormalities. Look at here. If you look at this, the patient's functional residual capacity is, this is normal. This is in an obese. See how much it has been reduced. Expiratory reserve volume should be this much. It is reduced this much. So the airway diameter, look, this is the normal diameter. Look at the diameter in an obese patient. And altered airway smooth muscle structure and function. So there is so much of difference even in the smooth muscle structure and function in the obese. Presence of OSA. It increases the risk of critical respiratory events immediately after surgery, including early hypoxemia and unplanned reintubations. Patients with 4% oxygen desaturation index of more than 5 were more likely to have post-operative respiratory complications. Coming to pulmonary hypertension, regardless of the etiology, if the patient has pulmonary hypertension, they are susceptible to post-operative pulmonary complication. So with heart failure, presence of heart failure is even higher risk than COPD. The general health status, if there is functional dependence, and look at this old man, and impaired sensorium, all of them will increase the risk. The inability to exercise itself, there is a 79% risk of pulmonary complication. Now we come to the procedure-related risk factors. The surgical site, it is a single most important factor in predicting the overall risk of post-operative pulmonary complication. It is significantly higher for thoracic and upper abdominal surgeries than for lower abdominal or other surgeries. And the impact of laparoscopic surgery on pulmonary complication rate is not actually very well established. Not many people agree that laparoscopic surgery is only the best, especially in few surgeries like pediatric lap hernia surgeries and things like that. Duration of surgery, surgical procedures lasting more than 3 to 4 hours are associated with a high risk. A less ambitious, briefer procedure should be considered in a very high risk patient. And the type of anesthesia, obviously GA more than the regional. Regional nerve blocks is associated with lower risk and should be considered when possible for high-risk patients. And long-acting neuromuscular blockers can have post-operative residual effects leading to higher incidence of post-pulmonary complication. So when a patient comes to you in your OPD, look at the gait, look at the BMI, look for the phenotype of COPD the patient. Is it a pink puffer, or or the patient is having cough with expectoration, whether it is bronchitis, whether it is emphysema. Ask and assess allergies, asthma. Ask about his sleep, snoring, smoking, breathlessness, and for any past treatment for any kind of comorbidities. History of exercise intolerance, chronic cough, and unexplained dyspnea should raise a bell in your ear. The physical examination may identify findings suggestive of unrecognized pulmonary disease like decreased breath sounds, dullness on percussion, wheezes, rhonchi, prolonged expiratory phase, etc. It's very easy for you to do a bedside PFT. You don't have to go to a spirometry to understand the dynamic functions of the patient. A simple bedside test also will help you to assess the patient's reserve. Best is to know the breath holding test. I'm not going to go into details. All of you all know more about it. Again, it is a crude assessment of the vital capacity of the patient. Snyder's match blowing test. Again, a crude assessment of maximum breathing capacity and FEV1. If the patient is able to blow the match at about 6 feet then you know that at least the maximum breathing capacity is more than 60 liters per minute and FEV1 is at least more than 1.6 liters per minute. So coming to the cough test, we know if the patient is unable to generate an effective cough, then we know that the FVC is less than 20 ml per kilogram, FEV1 is less than 15 ml per kilogram, and the PEFR is less than 200 ml per minute. And forced expiratory expiratory time test, again knowing whether it is more than less than 3 seconds or more than 6 seconds, you know whether it is obstructive or restrictive kind of pathology. De Bono's whistle test, again, it's a very useful test to understand the peak expiratory flow rate. The patient blows down the tube, the whistle sounds only when the rate of airflow exceeds a certain flow. So whether it is at 200, if the patient is able to generate the sound, then at this particular point at least it is 200, 300, 400, that way. So that is there. Similarly, peak expiratory flow rate also does the same. So we can have a useful assessment, especially in COPD patients. Another value of bedside PFT is to understand the pulse oximetry. In our OPD, we should use the pulse oximeter and test over there and look at the saturations in these patients. What about bedside spirometry? I'll come to the debate of whether we should do it or not. So and what should be done. So here, the spirometry, one of the valuables, the dynamic tests which we have to look into is the FEV1 and the FVC. The FEV1 is the patient takes a deep breath and blows out completely. And when he does that, the volume of air expired in the first second is the FEV1, and the volume of air expired during the entire forced expiration is the forced vital capacity. And if you look at it, the FEV1 should be at least 80% of FVC. So that has to be determined. And now coming to, there is a considerable debate regarding the role of preoperative pulmonary function testing, and the recommendation, again based on ACP guidelines, is not to use spirometry routinely. So we have our bedside functions tests, do them. So who should get the spirometry? So reasonable approach is obtain PFTs for patients with COPD or asthma. If clinical evaluation cannot determine if the patient is at their best baseline and that airflow obstruction is optimally reduced, obtain PFT for patients with dyspnea or exercise intolerance that remain unexplained even after clinical evaluation. It should not be used as the primary factor to deny any surgery, should not be ordered routinely prior to abdominal surgery or even other high-risk surgeries. So the high-risk patient is a high-risk patient in whom aggressive perioperative management is warranted, and ASA class 3 and those with chronic mucus hypersecretion, for them we need to use spirometry. What about ABG? So it's that use ABG only if it influences your perioperative management. So current data do not support the use of preoperative ABG in all your patients. Only you have to know if the patient is a COPD and is having current shortness of breath for whatever reason, then you can have to do an ABG in the patient. Exercise testing, there are no data to support its routine use in the evaluation of patient prior to general surgery. Now coming to chest X-ray. The availability literature does not allow an evidence-based determination of which patient will benefit from an X-ray, because you may find some findings over there which may not be actually useful. So if the patient has 2 or more patient-related factors, then go for an X-ray on that patient, or in a patient who has a known cardiopulmonary disease. And if the patient is coming for very high-risk surgical procedures like upper abdominal, aortic, esophageal, or thoracic surgeries. Again, look at the BUN and albumin. If there is elevated BUN or reduced albumin level, it is possible that this patient can go into postoperative respiratory failure. There are many indices available nowadays to understand and risk the patient. So they are the cardiopulmonary risk index. This takes into consideration obesity, cigarette smoking within 8 weeks of surgery, productive cough within 5 days of surgery, diffuse wheezing or rhonchi within 5 days of surgery, FEV1, FVC less than 70%, and PaCO2 of more than 45. So what do you think after talking about entire Ramayana, you cannot ask me how is Sita related to Rama, right? So in this, I just told you all of them should not get ABG, all of them should not get X-ray, all of them should not get spirometry. So this index is asking for the very same thing, which I told you that we should not ask. So now that is the limitation of this index. Brooks-Brunn risk index is again the next one, where you talk about age more than 60, obesity, impaired cognitive function, history of cancer, smoking history in the past 8 days, and upper abdominal incision. So they take these into consideration and then they stratify. One of the best indices so far is the ARIS-CAT score, which takes into consideration 7 risk factors: age, less than 50, 51 to 80, more than 80, they have a score. Preoperative SpO2, over 96, 91 to 95, less than 90, and again, look at the score over here. And then respiratory, infection in the last 1 month, preoperative anemia, surgical incision where it is, again they put in a score, duration of surgery if it is more than 2 or 3 hours, and if it is an emergency surgery. And based on the score, it is the patient is low risk for post-operative pulmonary infection, post-operative pulmonary complication. If it is less than 26, intermediate is up to 45, high risk is more than 45. I'm just finishing it. So the risk reduction strategies is smoking cessation of more than 8 weeks, bronchodilator therapy, lung expansion techniques, and inspiratory muscle training, such as incentive spirometry, IPPB, deep breathing exercise, CPAP in obese, and preoperative 30-minute chest physiotherapy before operation by manual pressure applied on patient's chest wall, or deep inspiration followed by slow expiration, and considering the patient for laparoscopic over open surgeries. And during intraoperative period, avoid GA if possible. And if you're using it, use low tidal volume with PEEP. Avoid volutroma, barotrauma, and atherectroma. Consider intraoperative salbutamol puff for patients having asthma through the endotracheal tube. Aspiration precautions and selective use of NG tubes, because that can increase the incidence of and vomiting and post-operative nausea or vomiting, inability for oral intake, or symptomatic abdominal distension. Only these are the ones who needs the NG tube. Give them good analgesia, continuous oxygen and blood pressure monitoring, using short-acting and intermediate-acting neuromuscular blocking drugs, and of course, goal-directed fluid therapy, which we learned all this while. So here, if the patient is low risk, go ahead. If the patient is high risk, look at the operative factors and the patient factors, and if needed, order an X-ray depending upon if there are more than 2 patient factors. And if the respiratory finding, and if you find the patient is having respiratory problems, do an ABG. If there is cardiac problems, you can do an ECG or echo. And if it is an emergency surgery, you'll have to optimize instantly and go ahead with the surgery. If the patient is having elective surgery, optimize with proper cessation of smoking, CPAP, inspiratory muscle training, salbutamol, chest PT. Intraoperative, I told you what to do. And postoperatively, similarly use the same strategies in the postoperative and go ahead with the elective surgery. So in summary, postoperative pulmonary complications are an important source of perioperative morbidity and mortality. A careful history and physical examination are the most important tools for preoperative risk assessment in evaluating patients for potential postoperative pulmonary complication. There is no role for ABG, routine X-ray in these patients. PFT should be reserved for patients with uncharacterized dyspnea or exercise intolerance, and for those with COPD or asthma, where clinical evaluation cannot determine if airflow obstruction has been optimally reduced. Thank you very much.
Thank you, ma'am, for this wonderful, comprehensive lecture. Ma'am, I would like to ask a doubt, especially in children with URI. So ideally, we have to wait maybe 4 weeks for an elective surgery to be done. But in clinical practice, it is very difficult for us to wait for 4 weeks. Even the surgeons also would not agree for that. So, ma'am, how do you go about it?
You mean a patient with a
URI, upper respiratory tract infection? Yeah, for elective case.
Patient is actively having fever with URI?
No, ma'am. No, like without. No, like had a fever, maybe just 1 day back or 2 days back, and now resolved. And do we wait for 3 weeks, or we just go about with the surgery?
To tell you frankly, we have to wait for 2 weeks. But even in our own centers, we don't actually wait. But then what we do is we use an LMA as far as possible, and we remove the LMA, and of course maintain good depth of anesthesia, and we remove the LMA much before, as soon, and we mask ventilate the patient, and so that we want to avoid bronchospasm, laryngospasm in these patients.
We give steroid cover and
not all the patients.
No need.
No.
Thank you, ma'am.
One question. Yeah. What I'm saying that in case of hernia, nowadays surgeons many times they post under laparoscopy. but sometimes patient may not be amenable for general anesthesia. And we cannot dictate surgeons. They say we already told patient that it will be done through keyhole. So what is your experience? Have you been successful in forcing the surgeon to go for open procedure in hernia?
And how bad was the lung function?
The patient is having a COPD, a case of COPD,
If
consistent.
it is a controlled COPD, I have done lap hernias under second generation LMAs.
Yeah. No, we do, but as you said, that patient will have a depressed respiratory function even in normal patient up to 1 week. So with that thing, is it not better if we do it as an open procedure under spinal?
It is always better, but I agree with you that spinal anesthesia is, you should go for, as I already told you in that presentation, avoid GA if you can.
Yeah.
It is better, but to tell you very frankly about surgeons are insisting on lap hernia. If you can convince them, that's the best thing to do. But then keyhole surgeries, especially hernia, to tell you very frankly, you can look into their literature also, which says that lap versus open, there is no difference. There is no difference in the outcome. So even in their own literature, it is there. But it is, I think it is an individual, the surgeon's, wish or his own, to do the surgery only under lap. That is the only thing.
One more question. Would you like to routinely advise some post-op respiratory chest physiotherapy?
Yes, of course.
Routinely, yeah. It's better because of up till 1 week.
Especially if the patient is having a COPD or, a known case. They have to go for a post-operative good physiotherapy, yes.
Thank you. Floor is open for discussion. If anybody having any questions from the crowd, please come.
In fact, even in pediatrics, we have tried to argue, why do you want to do? It's like idiopathic hypertrophic pyloric stenosis. A simple small incision, open incision, you go in, you do just put a, put an incision and just come out within 15 minutes. Pylomyotomy doesn't take anything more than 5 minutes. What is the point in doing laparoscopic and doing it for 45 minutes, 1 hour, 1.5 hours? So we have tried to explain it out with the surgeons. But as I told you, and we have in fact showed them many studies, their own studies, to show that lap versus open, sometimes, you can't make out the difference between the two. There is no difference in the outcome.
Economy is playing a bigger role here for surgeon's point of view.
Very true, very true.
Any questions from the floor? If not, we can wind up this session.
Yeah. Thank you so much.